The elbow, a deceptively complex joint. It's absolutely central to so many of our daily movements, from something as simple as lifting a cup of tea to a complex athletic maneuver. But that intricate anatomy also presents some unique challenges when things go wrong. Today, we're taking a deep dive into how modern medical innovation is truly transforming the way we diagnose and treat these issues, specifically through the powerful lens of elbow arthroscopy. We'll be uncovering the remarkable evolution of these minimally invasive techniques, exploring the foundational principles that keep patients safe and procedures effective, and then delving into the diverse array of conditions this approach can tackle. This deep dive is designed to give you, our discerning medical audience, a really comprehensive and clinically relevant perspective on this fascinating and rapidly advancing field.
Indeed. Our mission today is to truly unravel the nuanced clinical insights, the technical considerations, and the very latest advancements that empower surgeons to deliver exceptionally high-quality patient care in elbow arthroscopy. We aim to highlight both the well-established best practices and the incredibly exciting new frontiers in this specialty.
Let's set the scene then. Historically, the elbow was considered a particularly daunting joint for endoscopic exploration. It was almost a no-go zone for minimally invasive techniques, wasn't it? What exactly contributed to that perception, and how dramatically has that landscape shifted over time?
That's a great question, and it really speaks to the ingenuity within our field. You see, the elbow's inherent complexity, its tight anatomical spaces, the way vital neurovascular structures are packed so closely together, it genuinely made early endoscopic attempts quite challenging. There was a real apprehension around working in such a confined area with so many critical structures nearby.
Understandably so.
However, over the last few decades, we've witnessed a profound transformation. Our anatomical understanding has dramatically deepened, and we've seen truly groundbreaking technological advancements. Think about the incredible leap in optics, miniaturization of instruments, and even fluid management systems. These innovations haven't just allowed us to standardize our techniques, they've actually opened up a much broader range of conditions that we can now effectively address with arthroscopy.
That's fascinating. So it's not just about getting better at what you do, but about unlocking entirely new possibilities.
Precisely. And organizations like the Isagos Global Connection are instrumental in this evolution. They're actively fostering global education, research, and international collaboration. Their aim is to level that educational playing field, ensuring that more surgeons worldwide gain access to these advanced techniques and expert guidance, ultimately elevating the standard of patient care globally. When you look back to pioneers like Mori and his colleagues in 1981, they meticulously defined the elbow's functional motion, typically between 30 and 130 degrees of flexion. But with modern advancements, our indications for arthroscopy have expanded significantly. We can now intervene for conditions where even a subtle loss of range of motion can be absolutely debilitating.
Right.
Especially for elite sportsmen and manual workers who rely on every single degree of movement for their livelihood and performance.
So a small decrease in motion might seem minor to some, but for these patients, it's potentially career-ending. Arthroscopy steps in to reclaim that crucial function. That's a powerful shift.
A very powerful shift, yes.
Every surgical procedure, regardless of its complexity, hinges on meticulous preparation. With something as intricate as elbow arthroscopy, the initial patient setup must be absolutely critical. Could you walk us through the primary patient positioning options and the crucial considerations for anesthesia?
You're spot on. The initial setup truly is the bedrock for both patient safety and surgical efficiency. We primarily use three main patient positions, each with distinct advantages and disadvantages. The choice often comes down to the surgeon's preference and, crucially, the precise location of the pathology we're addressing. First, there's the lateral decubitus position, which was popularized by O'Driscoll and Mori back in 1992. Here, the patient lies on their side, securely supported by a beanbag or bolsters. The arm we're operating on is then placed on a padded bolster. What's critical about this position is that it allows for complete, unimpeded elbow flexion and extension throughout the procedure. It also offers the anesthetist excellent access to the patient's airway, and for us, the surgeons, it provides superb mobility to assess the elbow's full range of motion, allowing easy access to both the posterior and anterior compartments. It's a very stable position for the arm. The only minor drawback is that if, unexpectedly, an open anterior procedure becomes necessary, it might require a brief repositioning of the patient.
Okay.
Then we have the supine position, first described by Andrews and Carson in 1985. In this setup, the patient lies on their back with the shoulder abducted to 90 degrees and the elbow flexed to 90 degrees. The arm is then suspended using an overhead traction device. The primary advantage here is that the arm is in a more anatomical position, which can make surgical orientation feel more intuitive. It provides straightforward access to the anterior compartment, and again, the anesthetist has direct and easy access to the airway. A significant benefit is that the traction can be very easily released if an open procedure becomes necessary. However, accessing the posterior compartment can be more challenging.
Right, I can see that.
And the overhead traction setup needs careful management to minimize sterility risks, or may require an additional assistant.
Fair enough.
A variation that's gained popularity is the modified supine position. Here, the patient's shoulder is flexed to 90 degrees, and the arm is gently brought across the chest. This clever modification dramatically improves access to the posterior compartment compared to the standard supine position, a huge plus. We can easily suspend the arm using various mechanical devices, which are also highly adjustable during the procedure. And importantly, with the arm positioned across the chest, the vital anterior neurovascular structures tend to naturally fall away from the joint capsule. This significantly enhances safety when we're working in the anterior compartment.
That sounds quite advantageous for safety.
It certainly is. Finally, there's the prone position, which Poling and his team popularized in 1989. While it had its proponents, it's less commonly used now. The main reasons are the inherent difficulties in positioning the patient comfortably and safely, and critically, the limited access for the anesthetist to the patient's airway, which, as you can imagine, is a significant safety concern.
It sounds like each position has a thoughtful rationale behind it, balancing access with safety, doesn't it? And what about anesthesia? What's the consensus there?
Well, regarding anesthesia, both general anesthesia and regional nerve blocks are viable options. However, many surgeons, myself included, tend to lean toward general anesthesia. The main reasons are enhanced patient comfort and achieving complete muscle relaxation, which is crucial. This prevents any unintended patient movement during the delicate surgical procedure and naturally avoids the potential complications that can sometimes arise from a regional block. The trade-off, though, can be slightly longer post-operative recovery times and, paradoxically, sometimes more immediate post-operative pain. Some surgeons also prefer to avoid regional blocks so they can accurately assess nerve function immediately after the surgery, without any lingering effects from the block that might confound their assessment.
That makes sense, wanting that clear neurological picture post-op.
Exactly. Beyond positioning and anesthesia, there are several foundational preoperative principles that are absolutely essential for a safe and successful procedure. Firstly, we meticulously pad all bony prominences to prevent pressure injuries. The surgical setup must also allow us circumferential access to the elbow and, crucially, facilitate unimpeded elbow flexion throughout the procedure. This full range of motion is vital for safe portal placement and a comprehensive evaluation of the joint's interior. Another critical safety step is maximal distension of the joint capsule. We achieve this by injecting normal saline into the lateral soft spot, that triangular area between the lateral epicondyle, the olecranon tip, and the radial head, or sometimes posterocentrally, into the olecranon fossa with the elbow flexed.
And that inflation helps create space.
Precisely. This distension significantly increases the space between the bone and critical nerves. For instance, it increases the distance to the median nerve by about 12 millimeters and to the radial nerve by 6 millimeters, which genuinely creates a safer working environment. However, and this is absolutely vital to remember, this fluid injection does not increase the distance to the ulnar nerve, which, as you know, remains intimately close to the capsule medially.
So no complacency there.
None at all. A practical tip is that a slight 20-degree tilt of the operating table towards the surgeon can also be quite useful, helping to avoid compression of the antecubital fossa. Finally, before we even make the first incision, all bony landmarks, the course of the ulnar nerve, and all proposed portal sites are meticulously marked on the skin. And a tourniquet is then inflated on the upper arm just as the surgical procedure begins, ensuring a bloodless field for crystal clear visualization.
That really underscores just how much thought goes into setting the stage before you even pick up an instrument. It's truly a dance between anatomical knowledge and technological precision. Absolutely, it sounds like every millimeter counts. So once you're set up, understanding the precise entry points, what you call the portals, and the surrounding anatomy becomes paramount to avoiding complications. What are the key principles for safe portal placement, and could you give us a sense of how you choose and use these entry points?
This is truly where surgical artistry meets anatomical science. Precision is absolutely paramount here. We rely on extensive cadaveric studies that have meticulously mapped the neurovascular relationships around the elbow, allowing us to define critical safe zones for portal placement. Every single portal site is chosen with the utmost care and thoughtful consideration to prevent neurovascular injury, and bony landmarks serve as our primary guides for accurate entry.
So the landmarks are your map, essentially.
They are. Let's discuss the general principles that underpin safe portal placement. As I mentioned earlier, joint distension with normal saline at the very start of the procedure is a non-negotiable safety measure. It significantly increases the space between the bone and the median and radial nerves, creating a larger and safer working area inside the joint. But, and this is a critical point I'll reiterate, fluid injection does not increase the distance from the capsule to nerves like the ulnar nerve, which remains in very close proximity.
So it's not a universal shield then. You still need to be extremely vigilant with certain nerves.
Exactly. To further enhance safety, we ensure the elbow is kept in 90 degrees of flexion, and we consistently aim for more proximal anteromedial and anterolateral portals. This positioning naturally increases the distance from the portal entry point to nearby nerves. We also always use small caliber blunt switching sticks. These allow us to carefully palpate the joint and confirm we're truly inside the articular space before we introduce the arthroscopy trocar.
A crucial check.
It is. This simple step is fundamental in preventing any inadvertent extracapsular insertion. And of course, cannulas should always be used with these portals, providing a protective sheath for our instruments.
Right. Now tell us about some of the specific portals you use.
Certainly. Let's look at some of the widely used specific portals. The anterolateral portal is traditionally positioned about 2 cm distal and 2 cm anterior to the lateral epicondyle. While it offers good visualization, it's worth noting the radial nerve can be as close as 3 mm, and the posterior antebrachial cutaneous nerve as close as 2 mm, especially if the elbow is in extension.
Very close indeed.
Yes. It passes through specific muscles, and we aim the trocar towards the center of the joint. It provides excellent views, but many surgeons now prefer the proximal anterolateral portal due to the heightened radial nerve risk here. The proximal anterolateral portal is located slightly differently. 2 cm proximal and 1 cm anterior to the lateral epicondyle. This position is generally preferred precisely because it offers a significantly higher margin of safety from the radial nerve.
Okay. Safety first.
Always. We typically establish it using an outside-in technique, gently advancing a blunt instrument through the brachioradialis muscle. It gives us excellent views of the front and inner aspects of the joint, and particularly good views of the medial capsule and the anterior bundle of the medial collateral ligament. While it offers a slightly lesser view of the radiocapitellar and medial ulnohumeral joints compared to its more distal counterpart, its enhanced safety profile often makes it the go-to choice.
It sounds like a trade-off then. Slightly less comprehensive view for a significantly safer entry. That's a crucial clinical decision.
Precisely. Next, the proximal anteromedial portal. This one starts 2 cm proximal to the medial humeral epicondyle and anterior to the intermuscular septum. Cadaveric studies have repeatedly shown this portal to be further from major neurovascular structures, making it a relatively safe entry point. We direct a blunt trocar towards the center of the front of the joint. Now, if a patient have a history of ulnar nerve transposition or previous medial elbow surgery where the anatomy might be altered,
You need extra caution.
absolutely. In those cases, we would always opt for a small 2 to 3 cm skin incision to allow us to directly dissect down to the capsule for precise and safe placement, avoiding any blind entry.
Makes perfect sense. And the posterior portals.
Moving to the back of the elbow, the posterocentral portal is created 2 cm proximal to the tip of the olecranon, right in the midline, with the elbow flexed to 90 degrees. It passes through the triceps muscle just above where it blends into its tendon. It's important to avoid placing this too distally, as that could risk injury to the triceps tendon itself. The posterior antebrachial cutaneous nerve and the ulnar nerve are generally a safe distance away here, around 23 mm and 25 mm respectively, so injury is unlikely with proper placement. Finally, the posterolateral portal is located 2 cm proximal to the olecranon tip, but at the lateral border of the triceps tendon. For both posterior portals, we consistently direct the trocar towards the olecranon fossa at a 45-degree angle, again with the elbow flexed to 90 degrees. When we're working from these posterior portals, we get a clear view of the back of the trochlea, the tip of the olecranon fossa itself, and both the lateral and medial gutters or recesses of the joint capsule. It's absolutely critical to exercise extreme caution when debriding or working in the medial gutter.
Why specifically there?
Because the ulnar nerve lies incredibly superficially to the joint capsule, and the posterior bundle of the ulnar collateral ligament in that specific area. This close proximity poses a significant and ever-present risk of nerve injury if precision is not absolutely maintained.
That attention to detail is truly remarkable. It's clear that while arthroscopy is minimally invasive, the surgeon's anatomical mastery has to be maximal. The key insight here is truly the balance between precise portal placement and an intimate knowledge of the surrounding neurovascular structures, making patient safety the absolute priority. Given that foundation of safety and precision, let's now turn our attention to specific conditions. Osteochondritis dissecans, or OCD, is a challenging condition, often seen in young, active patients, causing pain and severely limiting motion. How do you approach its diagnosis and management, and what transformative role does arthroscopy play here?
Osteochondritis dissecans of the capitellum is, as you say, a common and often incredibly debilitating issue, particularly in young athletes like baseball pitchers and gymnasts. These individuals frequently present with a frustrating loss of terminal extension in their elbow, and in later stages they might experience mechanical symptoms like clicking, catching, or even locking. For diagnosis, our physical examination often reveals a clear deficit in elbow motion, localized tenderness over the capitellum, and frequently a positive radiocapitellar compression test, where we load the elbow axially in full extension while pronating and supinating the forearm. It's absolutely crucial to distinguish OCD from Panner's disease. While Panner's can present similarly, it typically affects much younger children, usually between 7 and 12 years of age.
Right, the age difference is key.
It is. And importantly, Panner's usually follows a self-limited course, often resolving with just rest and observation within about a year.
So Panner's is almost a watch-and-wait situation, whereas OCD often demands more active intervention.
Exactly. Imaging is vital for OCD. While CT scans, in both 2D and 3D, are excellent for pinpointing and detecting loose bodies, MRI is generally our preferred modality for early OCD detection, especially when plain X-rays look normal. MRI allows us to meticulously evaluate the chondrule, the cartilage surface, and is instrumental in differentiating between stable and unstable lesions. Recent studies show MRI sensitivities for unstable lesions ranging from an impressive 84% to 100%.
Very sensitive.
Yes, though it's worth noting that specificity can be lower, around 44% in some staging criteria, highlighting the need for strong clinical correlation.
So you need the clinical picture alongside the scan.
Always. When it comes to management, for stable early-stage OCD lesions, our initial approach is conservative. We cease repetitive stress on the elbow and observe the patient carefully. If, however, symptoms don't resolve within 3 to 6 months, we then consider surgical management. For unstable lesions, or those that fail to respond to conservative measures, or if there are loose bodies present, surgery truly becomes the treatment of choice, as these unstable lesions often remain symptomatic and progressive. Shai and colleagues in their work actually proposed a more refined classification, noting that uncontained lesions, not just unstable ones, correlated with greater preoperative and postoperative flexion contractures and higher rates of joint effusions, which further informs our surgical planning.
That makes perfect sense. And this is where arthroscopy truly shines, I presume.
Absolutely. Arthroscopic surgery is now widely recommended as the first-line treatment for OCD. Open procedures are generally reserved for cases where arthroscopy has been attempted and failed. The beauty of the arthroscopic approach is its proven track record. Excellent results, high patient satisfaction, and critically, no progressive loss of motion in reported series. We typically place the patient in the lateral position, often using a modified arm holder for stability. An arthroscopic pump with pressure monitoring ensures precise fluid management, and notably for this specific procedure, a tourniquet is often not used.
Oh, interesting. Why not?
Well, omitting the tourniquet can potentially optimize blood flow to the healing area, which might be beneficial for these chondral lesions. Our main working portals are usually the proximal medial and anterior lateral, and we employ motorized shavers and grasping forceps for debridement and meticulous fragment removal. A 70-degree arthroscope can be particularly advantageous here, providing a more complete panoramic visualization of critical areas like the coronoid fossa, any potential loose bodies lurking in the anterior joint, the posterolateral and posteromedial gutters, and the olecranon fossa radiocapitellar joint posteriorly.
That wider view must be incredibly helpful.
It really is. Baumgarten and colleagues developed a very useful grading system for OCD lesions, ranging from grade 1 to 5, which directly guides our decision-making. For instance, grade 1 lesions might be observed or drilled arthroscopically. Grade 2 lesions are carefully debrided back to healthy tissue. Grade 3 lesions are intentionally loosened to effectively become grade 4 lesions, and then they are resected. For grade 5 lesions, a meticulous, diligent search for any loose bodies is paramount. Importantly, all lesions with exposed bone are treated with abrasion chondroplasty to stimulate a healing response in the area.
So you're not just removing the problem, you're actively trying to promote healing in the bone beneath the cartilage. What if there's significant bone loss, though? Can you rebuild that arthroscopically?
That's a great question. And yes, for OCD lesions with significant bone loss, bone grafting can indeed be performed arthroscopically. This often involves placing the arthroscope in a posterior lateral portal, advancing it down the lateral gutter, and using that 70-degree scope to get a direct, clear view of the capitulum. We can then insert allograft cancellous bone plugs, typically size 1 to 2 millimeters smaller than the defect, to fill the void and help reestablish the normal convexity of the capitulum. These can sometimes be covered with a biologic patch or cartilage graft to further promote robust healing.
Remarkable. And what about outcomes? How do these patients fare long term?
In terms of outcomes and postoperative care, while good short-term results are consistently reported, long-term studies on OCD are still somewhat limited. However, arthroscopic debridement, drilling, microfracturing, or fragment fixation generally yield excellent return-to-sport levels for these young athletes. It's an important counseling point, though, that some patients might return to a different sport than before their injury. Osteochondral autograft, while it has the biological advantage of reproducing hyaline cartilage, does carry the potential for donor site morbidity, which is a consideration, especially given the relatively small size of elbow lesions.
Right, you have to weigh that up.
You do. Postoperative management typically involves a splint at 90 degrees flexion for 2-3 days, followed by immediate active and passive physical therapy. For those cases involving bone grafting, a hinged elbow brace is often used for 6 weeks to offload the lateral elbow, with early range of motion initiated within the brace and strengthening commencing at about 12 weeks. Return to play is generally permitted at 6 months, often contingent on a repeat MRI to confirm successful graft incorporation. The key insight here is that for OCD, arthroscopy offers a precision-guided, minimally invasive path to not just addressing symptoms, but promoting true biological healing and restoring function for active patients.
That's a truly detailed picture of OCD. Now let's turn to a condition that almost everyone has heard of, lateral epicondylitis, or tennis elbow. It's famously resistant to conservative measures. How has arthroscopy changed its treatment paradigm, and what's the evidence telling us about its effectiveness?
Lateral epicondylitis is, as you say, an incredibly common and often persistent source of elbow pain, especially frustrating when it becomes chronic and stubbornly resists non-operative approaches like injections or physical therapy. Historically, this condition was primarily managed with open surgical procedures, but arthroscopic approaches have truly revolutionized its treatment, offering a much less invasive yet highly effective option. To understand the pathology and diagnosis, the condition fundamentally involves the extensor carpi radialis brevis, or ECRB, tendon, which originates from the lateral epicondyle. Patients typically present with that characteristic lateral elbow pain, which is frequently exacerbated by passive volar flexion of the wrist or by resisting wrist dorsiflexion. Interestingly, in some cases, a lateral plica band, essentially a thickened fold of the annular ligament, can contribute to symptoms, even causing a palpable click with forearm pronation and supination. Mullet and colleagues have even meticulously categorized these plicae based on their relationship to the radial head. Arthroscopy is crucial here not only for confirming the diagnosis, but also for allowing us to precisely excise such a plica if it's found to be a pain generator.
So it's not just about the tendon. You're able to assess other subtle causes of pain within the joint itself.
Exactly. The arthroscopic technique usually begins by establishing a proximal medial portal using a nick and spread technique, aiming the trocar towards the joint center. Seeing fluid come out confirms our intra-articular entry. We then create a second portal, typically the proximal enterolateral portal, often using an outside-in technique with a needle to precisely localize the optimal insertion point. The initial steps involve careful debridement of the capsule. If indicated, we also perform a synovectomy or synovial fringe excision using a shaver. Many surgeons, myself included, prefer a monopolar radiofrequency probe for tissue resection in this area because of its malleability. It can be bent to conform to the elbow's contours, often proving more effective for precise tissue removal than traditional hand instruments.
More adaptable to the anatomy.
Precisely. For the actual ECRB release, the four-step technique described by Latterman and colleagues is a common and highly effective approach. This involves a partial resection of the capsule, followed by the precise resection of the ECRB tendon, both proximal and posterior to the extensor carpi radialis longus, or ECRL, and anterior to the lateral collateral ligament. Sometimes this also includes decortication of the ECRB origin from the lateral epicondyle, though that specific step is sometimes debated, with some clinicians expressing concern about potentially creating a new trigger point for pain.
Ah, potential downsides to consider.
Yes. Crucially, throughout this procedure, the surgeon must stay anterior to the radial head to meticulously avoid iatrogenic injury to the lateral collateral ligament, which is vital for elbow stability.
It sounds like a remarkably precise procedure, allowing for very targeted treatment. And what about the post-operative journey for patients?
The significant advantage of the arthroscopic procedure is that it allows for a comprehensive joint evaluation. Once the primary work on the ECRB is complete, we can switch portals to thoroughly inspect the entire anterior capsule, searching for any loose bodies or involvement of the coronoid trochlear articulation. The posterior compartment can also be visualized for the presence of a posterior radiocapitellar plica or posterior soft tissue impingement, which can be debrided if indicated, ensuring all potential pain generators are addressed in one go.
A proper clean sweep.
Exactly. For postoperative management, after wound closure, we apply a compressive wrap. Local anesthetic can be injected into the portals for pain relief, although we exercise caution with the medial portal due to its proximity to the ulnar nerve. Patients are encouraged to remove the sling as tolerated and begin active and passive exercises quickly, progressively working towards full extension. Rehabilitation involves a structured physical therapy program along with home exercises. Patients can often return to work as early as the next day, though a full return to strenuous activities like racket sports typically takes between 8 to 12 weeks to ensure full strength and endurance are regained.
And the results? Does it live up to the promise?
The results of arthroscopic treatment for lateral epicondylitis have been consistently positive and quite impressive. For example, long-term follow-up studies, such as those reported by Baker Jr. and Baker III, showed remarkable outcomes. In their 10-year follow-up study, patients reported mean pain scores of 0 out of 10 at rest,
Zero pain, that's fantastic.
with a resounding 93% stating they would undergo the surgery again if needed. Other investigators similarly report good results in over 90% of patients undergoing arthroscopic resection for this condition, strongly supporting its effectiveness and highlighting its significant improvement over traditional methods for many patients. The key insight here is that for chronic, stubborn tennis elbow, arthroscopy offers a minimally invasive, highly effective solution that addresses the underlying pathology with remarkable precision, leading to excellent, durable pain relief and return to activity.
That's incredibly promising for a condition like tennis elbow that can be so debilitating. Now let's pivot to elbow stiffness. Whether it's from trauma or degenerative causes, this can severely impact a patient's quality of life and their ability to perform even simple daily tasks, let alone athletic activities. What are the key indicators for arthroscopic intervention here, and how do you approach managing this challenging condition?
Elbow stiffness is indeed a very significant and often profoundly disabling problem. While Mori and colleagues back in 1981 defined the functional motion of the elbow as ranging from 30 to 130 degrees of flexion, for many individuals, especially athletes, musicians, or manual workers, even a small decrease outside this range can be functionally unacceptable, leading to significant disability and persistent pain. The causes and indications for stiff elbows are broadly categorized. We see post-traumatic stiffness, which is typically linked to a recent injury within 1 year. This could be from fractures of the olecranon, radial head, or coronoid, or from complex fracture dislocations. Then there's degenerative stiffness, which stems from long-term overuse syndromes, primary osteoarthritic changes, or as a lingering consequence of older traumatic events, often more than a year prior. Overuse syndromes are particularly prevalent in manual workers and sportsmen. Think javelin throwers, baseball players, boxers, weightlifters, and tennis players, where continuous high-impact training or heavy repetitive work can lead to early degeneration of the joint. Early stages of rheumatoid arthritis and osteochondrocathies can also be candidates for arthroscopic treatment. The presence of osteophytes, synovitis, and loose bodies frequently accompanies these conditions, all contributing to altered joint mechanics and accelerating degenerative changes.
So when does someone move from conservative management to being a candidate for arthroscopy for stiffness? What's that threshold?
The patient is typically considered a candidate for arthroscopic arthrolysis after a minimum of 6 months of failed conservative treatment, which rigorously includes dedicated mobilization, splinting, and intensive physical therapy. Crucial indications also include an intact articular space, the absence or only very mild anatomical incongruence, and a reduction in range of motion that specifically causes a disability related to their sport or occupation.
Okay, so functional limitation is key.
Very much so. Arthroscopy can also be used very effectively in conjunction with open surgery, particularly to avoid larger, more aggressive surgical approaches. However, certain conditions are generally excluded from arthroscopic procedures, such as muscle spasticity, cerebral paralysis, severe burns, previous surgeries that has led to significant anatomical ulcerations, expensive heterotopic ossifications, myositis ossificans, algodystrophy, articular instability, significant anatomic incongruence, and stiffness primarily due to active infection.
A clear set of exclusions. And the surgery itself. How do you approach an arthroscopic release for stiffness?
Regarding the surgical technique for stiff elbows, patients undergo general anesthesia. Following induction, we meticulously assess the patient's range of motion and perform a complete ligamentous balancing, often under fluoroscopy, to ensure the joint is stable. A tourniquet is inflated to 250 mm HG. The prone position is typical, with the shoulder abducted to 90 degrees, the elbow flexed to 90 degrees, and the arm held securely by a dedicated arm holder. Precise anatomical landmarks are meticulously drawn on the skin. We routinely use 5 portals, 3 posterior and 2 anterior. A critical initial step, particularly for stiff elbows, is often ulnar nerve neurolysis. This involves a small 2 cm skin incision to carefully isolate the ulnar nerve. This is absolutely essential to prevent the nerve from being overstretched during the crucial range of motion testing that we perform throughout the procedure.
Protecting the nerve before you even start moving the joint.
Precisely. Joint distension is then achieved by injecting 20 milliliters of normal saline through the soft spot portal. This is vital, as it helps to shift anterior neurovascular structures away from our working area, significantly enhancing safety.
So you start from the back then and then move to the front.
That's right. Posterior compartment arthroscopy is performed first. We typically use a 4.5 millimeter 30-degree arthroscope through the posterolateral soft spot portal, followed by a second, more proximal posterior portal. These 2 portals allow us to position the scope and shaver very effectively at the level of the posterior portion of the radial head. An arthroscopic pump maintains joint distension at a pressure of 35-50 mmHg. This approach facilitates a complete debridement of the olecranon fossa and its lateral wall, as well as the meticulous removal of any loose bodies. When we encounter osteophytes, if they are small, we protect the ulnar nerve with a retractor via an accessory portal and resect the osteophytes arthroscopically. For larger osteophytes, a small arthrotomy at the procedure's end may actually be preferred to avoid fluid extravasation and potential nerve compromise during arthroscopy.
A pragmatic approach for larger spurs.
Sometimes necessary. Following the posterior work, the arthroscope is moved to the anterior compartment via the superanteromedial portal. An anterolateral portal is often created using an inside-out technique. Here we perform anterior debridement, which includes the removal of loose bodies, anterior osteophytes, and a synovectomy. In cases of thick post-traumatic capsules, an anterior capsulectomy is frequently required. This begins by trimming the proximal humeral capsule with a shaver, but the main capsulectomy is then performed using basket forceps, about 1 centimeter proximal to the coronoid apex, working systematically from lateral to medial and then medial to lateral. During anterior capsulectomy, extreme care must be taken to protect the brachialis muscle, which becomes visible after capsule removal. This muscle can be very thin in stiff elbows, and due to its close proximity to the humeral artery, avoiding muscle bleeding is absolutely paramount to prevent subsequent calcifications and further stiffness.
That's incredibly detailed and frankly a bit daunting given the density of the anatomy. What happens immediately after such a complex procedure? I imagine rehabilitation is paramount here.
You're absolutely right. The postoperative protocol is perhaps the most critical component for maintaining the gains achieved intraoperatively. Immediately after arthroscopy, we meticulously assess the new range of motion. 1 or 2 suction drains are placed, and a splint holding the joint in full extension is applied to address any lingering extension loss. On day 1 post-op, patients begin very slow, continuous passive motion, or CPM, for 40 minutes, 4 times a day. This is often initiated with the help of those suction drains and a paranervous anesthetic catheter to manage pain and swelling.
Getting motion started right away.
Immediately. By day 2, the CPM sessions continue, augmented by 60 minutes of formal physiokinesiotherapy and self-active movements for 30 minutes, 4 times a day. This progressive increase in activity helps to gently challenge the joint. On day 3, the anesthetic catheter is removed and the intensive program continues. By day 4, the drains are removed and the rehabilitation continues at pace. On day 5, upon discharge, the patient goes home with a 20-day re-educational program to follow diligently. This is often combined with indomethacin, administered 3 times a day for 15 days, which helps to prevent heterotopic ossification or abnormal bone formation.
Yeah.
The splint, initially applied in full extension, is typically removed after 20 days.
That sounds like a very intensive first few weeks.
It is, and necessarily so. For the long term, the first follow-up visit is usually scheduled at 1 month, and the comprehensive rehabilitative program continues for a full 3 to 5 months. This aggressive protocol, while it can be linked to a slightly higher rate of minor complications like synovial leakage, has consistently shown better range of motion and overall results for our patients. Rehabilitation protocols are, of course, always modified based on individual patient needs and their progress. The improvement in Mayo Elbow Performance Index, or MEPI, scores postoperatively significantly contributes to a full recovery of working life, sports, and social relationships, alongside that crucial pain reduction. It's important to note that improvement in range of motion is often more considerable in extension than in flexion. This is because anterior capsulectomy, olecranon remodeling, and loose body removal primarily lead to a higher increase in extension,
Ah, interesting distinction.
whereas coronoid osteophyte resection and coronoid fossa trimming mainly favor elbow flexion. For specific flexion limitations caused by medial collateral ligament contractures, lysing the posterior part of the ligament through the ulnar neurolysis incision can be a beneficial adjunct. The key insight for elbow stiffness is that aggressive, immediate postoperative rehabilitation is as crucial as the precise arthroscopic release itself in restoring lost motion and function.
That comprehensive approach to stiffness truly highlights the marriage of surgical precision and post-operative dedication. Now, let's explore another significant challenge: elbow instability. This encompasses both valgus and posterolateral rotatory forms, which present complex diagnostic and treatment challenges. How do these conditions manifest for a patient, and how does arthroscopy assist in managing them?
Elbow stability is a marvel of biomechanics, relying on a delicate and complex interplay of static and dynamic soft tissue restraints and the intricate bony architecture. Any disturbance to this delicate balance can lead to truly significant functional impairment. Let's first discuss valgus elbow instability.
This is a painful disorder of the medial elbow, predominantly caused by acute or chronic injury or attenuation of the ulnar collateral ligament, or UCL. It was famously first described in javelin throwers, immediately pointing to its association with repetitive overhead activities.
The primary restraint to valgus stress during the throwing arc, typically between 20 to 120 degrees of flexion, is the anterior oblique ligament, or AOL, which is the strongest component of the UCL. Repetitive extreme forces can lead to microtrauma, ligament weakening, and eventually rupture. UCL insufficiency can result in what we call valgus extension overload, where increased contact forces between the olecranon and the posteromedial trochlea lead to bone spur formation and the presence of loose bodies. This causes pain, particularly posteromedially, and decreased extension as these osteophytes enlarge. Indeed. It can also cause radiocapitellar joint overloading, as the radial head tries to compensate at a secondary valgus restraint. This can lead to cartilage degeneration, more bone spur formation, osteochondral fractures, and further loose body formation. Ulnar neuropathy, or nerve irritation, can also occur due to nerve traction or swelling in the cubital tunnel.
So it's not just a ligament issue, it can cascade into problems with the bones and nerves as well. How do you pick it up on examination?
Precisely. For diagnosis, physical examination often reveals point tenderness approximately 2 cm distal to the medial epicondyle, slightly posterior to the common flexor origin. A thorough neurovascular exam is absolutely essential to rule out any associated ulnar neuropathy. Specific provocative tests are crucial. The milking maneuver involves the patient or examiner applying a valgus torque to the elbow. It's positive if it elicits pain or medial joint line widening. The moving valgus stress test, described by O'Driscoll and colleagues in 2005, involves the examiner applying constant valgus torque to a fully flexed elbow and then quickly extending it. It's positive if medial elbow pain is elicited and boasts an impressive 100% sensitivity and 75% specificity for medial pain.
High sensitivity there.
Very. Lastly, the abduction valgus stress test applies a valgus force at 30 degrees of flexion with the forearm in neutral rotation. It's positive if there's pain or medial joint line widening. Despite these tests, valgus laxity can be subtle and preoperative detection varies.
So diagnosis isn't always straightforward. What role does arthroscopy play then?
Arthroscopy's role is crucial, especially for indirect assessment, as only portions of the UCL can be directly visualized during the procedure, specifically 20–30% of the AOL and 30–50% of the POL. Studies by Timmerman and Andrews demonstrated that an intact AOL results in less than 1 millimeter of only humeral joint opening with valgus stress, elbow at 70 degrees, whereas a complete AOL sectioning leads to 3-5 millimeter opening.
Ah, so you can quantify the laxity.
Exactly. Field and Alchek similarly reported 1-2 millimeter widening after transecting the AOL. This allows for arthroscopic confirmation of AOL insufficiency by quantifying medial ulnohumeral joint opening with valgus stress. Although UCL reconstruction is fundamentally an open procedure, arthroscopy is invaluable for treating the long-term sequelae of UCL insufficiency.
The knock-on effects.
Yes, such as arthroscopic removal of posteromedial olecranon osteophytes, which offers less morbidity than open surgery, and the removal of loose bodies. It's important to note that patients with valgus extension overload should be thoroughly evaluated for UCL insufficiency, as some studies suggest that debridement alone, without addressing underlying instability, can lead to ongoing instability requiring reconstruction.
So arthroscopy is more about addressing the consequences of the instability rather than directly repairing the main ligament for valgus instability. That's a key distinction. Now, what about the other side, the lateral instability?
Indeed. Now let's turn to posterolateral rotatory instability, PLRI lateral. This condition causes severe dysfunction in daily activities like pushing off a chair or even shaking hands. Its recognition has grown significantly since O'Driscoll and colleagues' original description in 1991. Often, late recognition of this issue necessitates a more complex open reconstruction with a graft. Understanding the anatomy and mechanism, lateral elbow stability is maintained by the lateral collateral ligament complex, which comprises the radial collateral ligament, the lateral ulnar collateral ligament, LUCL, the accessory lateral collateral ligament, and the annular ligament. The LUCL, inserting on the supinator crust, is considered key. Its sectioning alone can induce instability. The typical injury mechanism involves a combination of forearm supination, a valgus load, and an axial load to the elbow. This force combination leads to a circumferential disruption of the ligaments and capsule, progressing through stages. Stage 1 involves LCL complex disruption and radiocapitellar ulnohumeral subluxation. Stage C sees further capsular disruption and incomplete perch dislocation. Finally, Stage 3 involves posterior elbow dislocation with posterior oblique ligament disruption, leaving only the AOL intact.
So it's a progressive injury if left unaddressed. And how do you diagnose this one on physical exam, especially if it's subtle?
For diagnosis, physical examination might show normal strength and range of motion, with minimal tenderness. Provocative maneuvers are key. The posterolateral rotatory instability test involves supinating the forearm and applying valgus and axial forces while flexing the elbow from full extension. It's positive if the radial head reduces or the patient shows apprehension under anesthesia. More recently, Regan and Lappner described apprehension tests like the chair sign, reluctance to fully extend the elbow when pushing off armrests with supinated forearms, and the push-up sign, apprehension with terminal elbow extension during push-ups with supinated forearms. These apprehension tests are considered more sensitive in awake patients, as they rely on the patient's discomfort rather than a gross instability.
Relying on the patient's feeling of instability.
Exactly. Arthroscopy is a very useful tool when physical exam is inconclusive for PLRI. During diagnostic arthroscopy, if we view the radiocapitellar joint from the anteromedial portal while supinating the forearm with the elbow flexed to 90 degrees, we will clearly see rotation and posterior subluxation of the radial head on the capitellum in patients with PLRI, unlike normal rotation without subluxation. This can also be observed from the posterior compartment, specifically the posterolateral gutter. A positive drive-through sign is also highly indicative, where the arthroscopes can actually be driven through the lateral gutter from the posterolateral portal right into the lateral aspect of the ulnohumeral joint, indicating significant laxity.
That drive-through sign paints a very clear picture of just how unstable that joint can become. So once diagnosed, how is PLRI treated arthroscopically? Can you repair it minimally invasively?
For arthroscopic treatment, for patients with functional impairment that's resistant to non-operative treatment, arthroscopic LCL complex repair and plication techniques have truly evolved. For acute or chronic avulsion from the humeral origin, an arthroscopic repair can be performed. We place a suture anchor at the humerus origin of the native LCL complex, typically viewed from the posterocentral portal. Sutures are then passed through the ligament and tied under the Ancones muscle with the elbow in full extension, effectively repairing the native ligament back to its origin. For chronic attenuation, arthroscopic plication is typically performed. This involves placing 4 to 7 absorbable sutures obliquely through the LCL complex, starting distally and moving proximally. The suture ends are passed underneath the LCL complex origin on the humerus and then sequentially tied outside the capsule to tension the ligament.
Tightening up the stretched ligament.
Exactly. If posterior subluxation persists after publication, a suture anchor can be placed at the lateral epicondyle's isometric point to pull the entire publicated complex back. Savoy and colleagues have reported significant improvement in outcomes with both arthroscopic and open techniques for PLRI, underscoring the efficacy of these interventions.
And post-op for that, how do you manage it?
Postoperative management for arthroscopic radial ulnohumeral ligament, or RUHL, repair typically involves a posterior splint with the elbow flexed to 30 degrees for 5-7 days. Subsequently, a hinged elbow brace allowing 0 to 45 degrees of flexion is used for 6 to 8 weeks. Tensioning the repair is performed with the elbow in pronation and 45-60 degrees of flexion to prevent any over-tightening. Full range of motion is generally expected by 6 to 8 weeks, followed by progressive exercises and strengthening. The key insight here is that for PLRI, arthroscopy offers not just a diagnostic tool, but an effective, minimally invasive repair option that can restore crucial lateral elbow stability, allowing patients to regain confidence in simple, everyday movements.
We've spent a lot of time discussing intra-articular pathologies, those within the joint itself. But as a medical audience, we know that endoscopic techniques have a much broader utility, extending to surrounding soft tissues. Could you elaborate on how these minimally invasive approaches are revolutionizing treatment for nerve entrapments and bursitis around the elbow?
Indeed, you're absolutely right. The principles of minimally invasive visualization and intervention have broad applications that extend well beyond the articular surface of the joint, proving particularly valuable in addressing pathologies and surrounding soft tissues. Let's start with endoscopic cubital tunnel release for ulnar nerve entrapment.
Ulnar nerve entrapment at the elbow is the second most common upper limb entrapment neuropathy, surpassed only by carpal tunnel syndrome. Common compression sites include the arcade of Struthers, the cubital tunnel itself, which is the most common site, and the fascia of the flexor carpi ulnaris. This can cause numbness, tingling, and weakness in the hand, affecting fine motor skills.
Indications and contraindications. It's indicated for cases of cubital tunnel syndrome, where conservative management, such as splinting, activity modification, or nerve gliding exercises, has failed to relieve symptoms. Contraindications include space-occupying lesions, a history of previous ulnar nerve release or transposition, and severe elbow contractures that would complicate the endoscopic approach. Interestingly, if the ulnar nerve is unstable, an anterior transposition, which involves moving the nerve, is necessary, and this can now also be performed endoscopically.
So rather than a big open incision, you're able to decompress the nerve with very small access points. How does that work? Is it similar to arthroscopy inside the joint?
For the technique, this procedure is typically performed under general anesthesia with the patient in a lateral decubitus position. It is crucial to highlight that this is often a dry endoscopic technique, meaning no irrigation fluid is used.
No fluid like in GN arthroscopy.
Correct. This avoids fluid extravasation into the soft tissues, a common concern in traditional arthroscopy. A small 3-centimeter longitudinal incision is made between the medial epicondyle and olecranon with careful blunt dissection down to the cubital retinaculum. A small fenestration is then made in the retinaculum, and a specialized device, such as certain endoscopic carpal tunnel devices adapted for the elbow, is introduced adjacent to the nerve under direct vision. This device features a pistol grip and a retractable cutting blade, allowing for precise release of overlying constrictive tissues both proximally and distally, while ensuring the nerve is meticulously protected.
Very precise release. And you mentioned even moving the nerve endoscopically.
Yes. For endoscopic ulnar nerve transposition, we first elevate the subcutaneous plane anterior to the medial epicondyle, then perform a standard endoscopic ulnar nerve release. Following that, the medial intermuscular septum is identified and meticulously released with careful protection or cauterization of adjacent vessels. The ulnar nerve is then mobilized and gently transferred anterior to the medial epicondyle. The incised deep fascia can be repaired endoscopically, often with barbed sutures, to prevent the nerve from herniating back into its original position. Crucially, we must always check the nerve for any kinking and ensure a proper stable bed is prepared for it in its new anterior position. Post-operatively, the elbow is placed in a sling inflection for 1 week to stabilize the nerve and facilitate soft tissue healing.
That's a significant advancement, moving a nerve endoscopically. What are the key takeaways in terms of outcomes compared to open surgery?
The outcomes are very compelling. Meta-analyses have shown that in situ decompression, that is, releasing the nerve in its original position, offers comparable outcomes to anterior transposition, but with significantly fewer complications. Endoscopic decompression, specifically, has been shown to be as effective as open decompression, with the distinct advantages of being less invasive, requiring a smaller incision, causing less vascular insult to the nerve, and promoting faster recovery.
Faster recovery is a big plus.
Definitely. Prospective studies have even reported better patient satisfaction and lower complication rates, including elbow pain, scar tenderness, and medial elbow paresthesia with the endoscopic technique. This really underlines the shift in thinking for nerve entrapments.
Fascinating. And what about bursitis, that prominent swelling at the back of the elbow?
Right, let's explore olecranon bursoscopy.
Olecranon bursitis is the most common superficial bursitis of the elbow, often presenting as that noticeable swelling. Roughly 1/3 of cases are septic, typically caused by Staphylococcus aureus, requiring urgent drainage, irrigation, and antibiotics. The remaining 2/3 are sterile, resulting from repetitive trauma, inflammatory conditions like rheumatoid arthritis, or crystal diseases like gout.
Surgical approach. For sterile cases, surgery is indicated when conservative treatment such as rest, ice, compression, and anti-inflammatories fails to resolve the swelling or pain. Traditionally, open excision was performed, but it often led to problematic wound healing issues because the incision is directly over the prominent olecranon.
Yes, that area doesn't heal well.
Exactly. Endoscopic techniques are now preferred as they use smaller incisions positioned away from the olecranon, preserving bridging skin and leading to significantly faster healing and reduced scar sensitivity. There are two main endoscopic techniques. The wet technique, similar to joint arthroscopy with saline inflow, where the bursa is resected from the inside out, and the dry technique, which is increasingly preferred for olecranon bursitis. This method uses hooded endoscopic equipment. A 2-3 centimeter incision distal to the bursa allows scope introduction. Subcutaneous tissues are elevated off the bursa and olecranon, and a pituitary rongeur resects the bursa through a separate proximal portal. Cautery is used for precise bleeding control. Postoperatively, the elbow is placed in a sling at 90 degrees flexion to gently close off the dead space created by removing the bursa.
That's fascinating. So even for something as outwardly simple as a bursitis, minimally invasive techniques are showing real advantages. What about the biceps tendon?
Absolutely. Finally, distal biceps bursoscopy.
This is indicated for bicipitorradial bursitis, an inflammation of the bursa under the distal biceps tendon, or for partial tears of the distal biceps tendon itself. Both can cause pain, sometimes radial nerve compression, or limitation of forearm rotation. The bursa normally envelops the tendon where it inserts onto the radius to reduce friction during rotation.
Endoscopy advantages. Endoscopy provides a magnificently magnified view of the pathology, allows for precise biopsy, and crucially, offers dynamic assessment of the distal biceps tendon through a range of motion. This is vital for seeing how the tendon moves and functions under load.
Seeing it in action.
Precisely. Technique. The patient is supine with the arm extended and supinated, with a tourniquet applied. A 2.5 centimeter longitudinal incision is made over the biceps tendon, 2 centimeter distal to the elbow crease, ensuring careful protection of the lateral cutaneous nerve of the forearm. A trocar and arthroscopic cannula are inserted into the bursa on its radial side, and normal saline is introduced via gravity feed. A pump is avoided here to minimize fluid extravasation into the surrounding tissues. The two distinct tendons of the distal biceps can be visualized, allowing dynamic assessment with a probe, forearm rotation, or traction. For treatment, debridement of synovitis or partial tears, specifically less than 50% of the tendon, can be performed with a full radius resector, but it is paramount to ensure the aperture is clearly in view to avoid neurovascular injury. For complete tears or tears greater than 50%, an endoscopic repair can be performed. The anatomic footprint on the radius is identified and debrided endoscopically.
Techniques like the endo-button method described by Sharma and McKay involve delivering the ruptured tendon, suturing it to an endo-button, and using the endoscope to guide reaming and secure the button onto the radial tuberosity, confirmed with fluoroscopy. This allows for a very strong anatomical repair.
That sounds incredibly technical, repairing a tendon endoscopically.
It requires specific skills, yes. Postoperative management. For debridement, immediate range of motion is initiated, with full activities and resistive exercises at 3-4 weeks. For tendon repair, immediate range of motion is crucial, followed by light activities at 4-6 weeks and strengthening beginning at 12 weeks. The key insight from these applications is that endoscopic techniques are increasingly extending their reach beyond the joint, offering less invasive yet highly precise solutions for common soft tissue pathologies and nerve entrapments around the elbow, leading to faster recovery and better cosmetic outcomes.
That's a truly expansive view of endoscopy's reach beyond the joint. Now, let's move to something historically synonymous with large open incisions: fracture management. How are simple elbow fractures being addressed with these minimally invasive arthroscopic techniques, and what are the specific benefits and indeed the challenges of this approach in the context of acute trauma?
You're absolutely right. The application of arthroscopy in fracture care is expanding significantly, offering a way to achieve precise reduction and stable fixation with considerably less soft tissue disruption compared to traditional open approaches. This is a real game changer for many patients. Let's consider the general considerations for elbow fractures. A history of traumatic injury, such as a fall, sporting injury, or a motor vehicle accident, is, of course, common. Clinical examination involves inspecting for open wounds, meticulously localizing pain, checking for crepitus, and assessing range of motion, which may be blocked due to the fracture. A careful neurological examination is absolutely critical with any fracture or dislocation, given the close proximity of vital nerves. Routine radiographs usually diagnose most fractures, but CT scans are invaluable for identifying any comminution, that is, multiple fragments, and for meticulously planning the surgical approach.
CT for the fine details.
Essential for planning. The indications for arthroscopic treatment are primarily for simple fractures, such as condylar fractures with a single fracture line, capitellar shear fractures, radial head fractures with 1 or 2 fragments, and large coronoid fractures. For capitellum and trochlear fractures, its use is generally restricted to specific cases. Type I, Hans-Steinthal fractures without posterior depression, Type 3 fractures, and crucially, the absence of combined ligament lesions that would necessitate a more open approach for stability.
So it's not for every fracture, but for specific ones where the benefits of minimally invasive surgery truly outweigh the complexities. What are those core technical principles you apply when you're dealing with a fracture arthroscopically?
Precisely. The technique principles involve typically placing the initial arthroscope in a proximal anteromedial portal to visualize lateral structures. Upon entering the joint, abundant hematoma blood from the fracture is common and must be evacuated using a shaver through a proximal anterolateral portal. Suction use, however, should be limited to avoid tearing the capsule and adjacent brachialis muscle, which could inadvertently bring the radial nerve into close proximity and risk injury. The shaver tip itself can also be used as a delicate probe to manipulate fracture fragments into their correct anatomical position.
Using the tools creatively.
You have to. Reduction is provisionally held with Kirschner wires, which is then meticulously confirmed by fluoroscopy, followed by definitive fixation with headless cannulated screws. It's crucial to explore all joint compartments arthroscopically to ensure no loose debris remains, which could cause future impingement or pain. Retractors are vital to minimize damage to neurovascular structures, and intra-articular pressure should be maintained below 50 mmHg with an arthroscopic pump. The use of multiple portals helps manage fluid leakage, and notably, sealed cannulas are generally contraindicated during posterior debridement to allow fluid to escape and prevent excessive pressure increase within the joint.
Managing that fluid pressure is key.
Critical. Now, looking at specific fracture types and techniques. For capitellum and trochlear fractures, the patient is usually positioned laterally. 3 arthroscopic approaches facilitate joint shaving and lesion planning, often with the arthroscope in the medial portals and working through the lateral ones. While some authors suggest elbow extension to facilitate reduction, in our experience, we often prefer to maintain 90 degrees of flexion, as extension can actually reduce the working space. After achieving temporary reduction and fixation, the fracture must be thoroughly explored posterolaterally, and the posterior compartment carefully checked for any loose bodies. Percutaneous fixation with cannulated screws can then be performed posteroanteriorly. In some cases, a small, mini-open incision might be used at the procedure's end to ensure optimal fixation, for instance, with resorbable screws and pins, all while meticulously avoiding radial nerve risk.
Combining techniques when needed.
Pragmatism is key. For coronoid fractures, surgical intervention is recommended for Regan and Mori type 3 fractures, which involve a significant portion of the coronoid, or any fracture interfering with joint motion, as these are crucial for restoring anterior and medial elbow stability. While isolated coronoid fractures traditionally required aggressive open approaches, arthroscopic techniques are increasingly effective. The arthroscope is placed in the proximal anterolateral portal to view the medial elbow. Fracture fragments are reduced and held, often with the assistance of a tibial anterior cruciate ligament drill guide. A guide pin is then drilled from the ulna's posterior cortex to engage the fragment. If the fragment is sufficiently large, a single cannulated screw can be placed postero-anteriorly to maintain reduction. For smaller or comminuted fragments, 2 drill holes can be made, and fragments can be lassoed with a suture tied over a bone bridge on the posterior cortex. Stable fixation is paramount to minimize the period of postoperative immobilization.
So even with fragmented bone, you can achieve a stable repair arthroscopically. That's incredible precision.
It is. Radial head fractures are very common and are classified by Mason and Johnston based on their displacement and comminution. The treatment choice, excision reduction and fixation or prosthetic replacement, depends on the number of fragments, displacement, involvement of other structures, and any associated ligamentous lesions. Open reduction internal fixation, or IF, or prosthetic replacement, offers better articular stability, particularly with a combined medial collateral ligament lesion. Isolated fractures might be treated with simple fragment excision if they interfere with range of motion, or full radial head excision if over 50% of the surface is involved. Arthroscopic radial head removal can be performed when comminution prevents fixation, the elbow is stable, and the patient is older. Fragments are removed from the anterior compartment, and the radial head is resected precisely using a burr through the midlateral portal, with the arthroscope in the anteromedial portal, cutting at the superior margin of the intact annular ligament, minimizing shortening to maintain lateral collateral compartment tension.
Careful resection to preserve stability.
Precisely. Finally, for condylar fractures of the distal humerus, the fracture line can be manipulated with a shaver tip or a freer elevator. A large bone reduction clamp can be placed on the medial and lateral epicondyles to reduce and compress the fracture. Direct visualization from the anterior compartment helps minimize articular cartilage step-off. Guide pins are placed under fluoroscopic guidance, and cannulated screws provide definitive fixation, crucially keeping the reduction clamp in place during drilling and screw placement to prevent any loss of reduction.
A combined approach using imaging and direct vision. What are the outcomes like, and are there significant risks with arthroscopic fracture fixation?
Regarding outcomes and complications, reported outcomes for arthroscopic fracture treatment are generally positive. Postoperative stiffness can occur, especially in post-traumatic cases, and may occasionally require further release. While some series have reported no neurological or vascular lesions, the risk of neurovascular injury remains due to the elbow's complex and dense anatomy. Arthroscopic treatment for fractures requires deep knowledge of traumatology and both open and arthroscopic elbow surgery, indicating it's a sophisticated technique that continues to evolve and demands a high level of surgical expertise. The key insight here is that for selected elbow fractures, arthroscopy offers a minimally invasive route to anatomical reduction and stable fixation, reducing soft tissue disruption and potentially accelerating recovery, but demands meticulous attention to safety in a notoriously unforgiving anatomical area.
Given the incredible precision and indeed the inherent risks you've highlighted, let's talk about complications. Even in the most experienced hands, these can arise. What are the more common and perhaps more serious complications associated with elbow arthroscopy, and crucially, what robust strategies do you employ to mitigate them?
This is a vital aspect of practice that truly demands our continuous attention and respect. General arthroscopy risks, which apply across joints, include infection, persistent fluid drainage from portals, and potential damage to articular cartilage. However, given the elbow's unique neurovascular density, that is, how tightly packed the nerves and blood vessels are, neurological complications are a particular concern and absolutely require meticulous preventative strategies. We primarily watch for neurological complications. Transient neuropraxia, essentially a temporary stunning or bruising of a nerve, of the anterior duracius nerve and median nerve, has been reported. This can sometimes occur after the removal of unusually large loose bodies or from direct pressure during the procedure. More seriously, direct permanent injury to the median and ulnar nerves can also occur, though thankfully these are rare. Protecting these critical nerves is paramount to the procedure's success and the patient's long-term well-being.
That's certainly the biggest concern for any surgeon operating in such a tight space. So what are the core strategies you implement to protect these nerves throughout the procedure?
To that end, we employ a multifaceted approach to nerve protection strategies. First, fluid insufflation is a primary measure. Distending the joint capsule with fluid significantly increases the bone-to-nerve distance, creating a larger and safer working space within the joint. However, it's crucial to remember that this fluid distension doesn't change the capsule to nerve distance, meaning the nerves still remain in close proximity to the capsule itself, so vigilance is key.
Okay, so space between bone and nerve, but not capsule and nerve.
Correct. Second, portal placement is meticulously planned. Keeping the elbow in 90 degrees of flexion and using more proximal anterior medial and anterolateral portals inherently increases the safe distance from the nerves to our entry points. Third, careful entry is essential. Using a small caliber blunt switching stick to carefully palpate the joint and confirm we're truly inside the articular space before introducing the arthroscopy trocar helps us avoid potentially damaging extracapsular insertion. Fourth, the consistent cannula use for portals is highly recommended as they provide a protective sleeve for instruments entering and exiting the joint, shielding the surrounding soft tissues.
Little things that add up to safety.
They really do. For the median nerves specifically, avoiding distal portals is key. We prefer a proximal anteromedial portal, positioned about 1 centimeter proximal and 1 centimeter anterior to the medial epicondyle to maintain a safer distance. During debridement of synovitis, osteophytes, or adhesions in the anterior ulnohumeral region, capsule protection is paramount. Extreme care is taken not to perforate the capsule, as this can directly lead to anterior interosseous or median nerve injury. A mid-anteromedial portal, if needed, can be created using an inside-out technique and used as an accessory portal for retractors to help maintain nerve distance. When transitioning compartments from anterior to posterior arthroscopy, anterior cannulas are ideally removed. If a drainage cannula is left in the proximal anteromedial portal during posterior arthroscopy, the median nerve seems less predisposed to complication. However, full elbow extension should be strictly avoided until all anterior cannulas are removed, as extension can create pressure between the radial or median nerves and any remaining anterior cannulas, predisposing to neuropraxia.
A subtle but important point about extension.
Very important. Regarding the ulnar nerve specifics, surgeons must be acutely aware of ulnar nerve hypermobility or subluxation, where the nerve slips out of its groove. This can predispose it to contusion or laceration during anteromedial portal creation. Iatrogenic injury can also occur if portals are created blindly, especially after a prior subcutaneous ulnar nerve transposition, which can alter its expected anatomical course. For subluxation, the nerve can often be gently held reduced behind the medial epicondyle while the portal is created. If the nerve's precise location is unclear due to previous transposition, a small 2 to 4 centimeter skin incision should always be made to meticulously identify and protect the nerve before creating the capsular portal. This is a non-negotiable safety step.
Open up if you're unsure.
Absolutely. When performing a capsule release for contracture, especially for less experienced operators, it's advisable to begin by releasing the capsule directly off the bone on the humeral side, as neurological structures can sometimes be scarred directly to the anterior capsule. More advanced techniques involve precisely incising the capsule across its width using a duckbill basket punch, meticulously visualizing the brachialis muscle, and dissecting neurovascular structures off the capsule, or even employing endoscopic extracapsular capsulectomy with retractors to maintain nerve distance.
So different levels of technique depending on complexity and experience. What are the overall complication rates like?
Despite these comprehensive precautions, complications can still occur. However, reported complication rates are generally low. For instance, a large series involving 212 patients from a single surgeon over 5 years demonstrated a low rate of neurological complications at 1.8%, and minor complications, such as synovial leakage or superficial portal infections, at 10.8%. While any neurological complication is serious, these rates are considered acceptable within the context of complex elbow surgery, reflecting the diligent application of these safety protocols. The key insight here is that while elbow arthroscopy is a powerful tool, it's the meticulous, multi-layered approach to nerve protection that underpins its safety and allows us to push the boundaries of treatment.
That's a truly comprehensive look at complication mitigation. Even with such meticulous technique, though, post-operative stiffness can still be a stubborn issue. What are the main risk factors for this, and how do you effectively manage it when it arises?
Post-operative contracture is indeed a known challenge following elbow arthroscopy. The risk is highest after surgery for post-traumatic elbow disorders, which can include arthroscopic contracture release itself and interventions for complex fractures. These elbows often have extensive scarring and inflammation even before surgery. The good news is that most cases of post-arthroscopy stiffness respond very well to a consistent and immediate regimen of active-assisted, and passive range of motion exercises. Early movement is key then. absolutely critical. Splinting regimens are routinely employed to help regain terminal flexion extension. This often involves a flexion cuff for daytime use and a nighttime extension splint. These apply gentle, prolonged stretches to regain motion. If progress is slow or plateaus, despite consistent therapy, static progressive splinting using a turnbuckle may be employed as a beneficial adjunct. This type of splint can apply incrementally increasing tension to help push through those persistent limitations. Unfortunately, in rare and often very complex circumstances, reoperation for revision contracture release becomes necessary, particularly when the initial injuries were severe or multifaceted, leading to more recalcitrant stiffness. The key insight here is that while postoperative stiffness is a risk, an aggressive and early rehabilitation protocol is the primary defense, and most patients respond well to these structured approaches.
It sounds like rehabilitation is truly where the gains from surgery are cemented. Could you give us a concrete example of a typical postoperative protocol, particularly for a stiff elbow, which seems to demand the most intensive approach?
Certainly. Functional rehabilitation must be immediate and sustained to maintain the range of motion achieved intraoperatively and minimize the inevitable risk of adhesion formation. Our rehabilitation protocol for a stiff elbow, for instance, is quite structured and intensive to truly maximize recovery. On day 1 post-op, rehabilitation begins immediately with very slow, continuous passive motion, or CPM, for 40 minutes 4 times a day. This is often initiated with the help of 2 suction drains and a paranervous anesthetic catheter to manage pain and swelling, allowing the patient to tolerate the early motion.
CPM from day 1.
Yes. By day 2, the CPM sessions continue, augmented by 60 minutes of formal physiokinesia therapy and self-active movements for 30 minutes 4 times a day. This progressive increase in activity helps to gently but consistently challenge the joint. On day 3, the anesthetic catheter is removed and the intensive program continues. By day 4, the drains are removed and the rehabilitation continues at pace. On day 5, upon discharge, the patient goes home with a 20-day re-educational program to follow diligently. This is often combined with indomethacin, administered 3 times a day for 15 days, which helps to prevent heterotopic ossification or abnormal bone formation. The splint, initially applied in full extension to correct any extension loss, is typically removed after 20 days.
It sounds incredibly structured and quite demanding for the patient.
It is, but it's crucial. For the long term, the first follow-up visit is usually scheduled at 1 month, and the comprehensive rehabilitative program continues for a full 3 to 5 months. This aggressive protocol, while it can be linked to a slightly higher rate of minor complications like synovial leakage, has consistently shown better range of motion and overall results for our patients. Rehabilitation protocols are, of course, always modified based on individual patient needs and their progress, and we work very closely with our physiotherapists. The improvement in Mayo Elbow Performance Index, or MEPI, scores postoperatively significantly contributes to a full recovery of working life, sports, and social relationships, alongside that crucial pain reduction. It's important to note, as we touched on earlier, that improvement in range of motion is often more considerable in extension than in flexion. This is because anterior capsulectomy, olecranon remodeling, and loose body removal primarily lead to a higher increase in extension, whereas coronoid osteophyte resection and coronoid fossa trimming mainly favor elbow flexion.
Tailoring the surgery to the specific limitation.
Precisely. And for specific flexion limitations caused by medial collateral ligament contractures, diffusing the posterior part of the ligament through the ulnar neurolysis incision can be a beneficial adjunct. The key insight here is that truly functional recovery in elbow arthroscopy, especially for stiffness, hinges on a highly structured, aggressive, and immediate post-operative rehabilitation protocol tailored to the specific anatomical gains achieved in surgery.
What an incredible journey we've taken through elbow arthroscopy today. From overcoming anatomical complexities and refining safety to addressing a remarkable range of pathologies and perfecting rehabilitation, it's clear this field is relentlessly pushing the boundaries of orthopedic surgery. Given all these advancements, what's truly on the horizon? Where do you see elbow endoscopy and arthroscopy evolving in the coming years?
The future of elbow endoscopy and arthroscopy is, frankly, incredibly promising, driven by relentless innovation in both technology and surgical technique. While wet endoscopy, similar to traditional arthroscopy with fluid distension, has been the mainstay for over 40 years, dry endoscopy of the upper limb is a relatively new and rapidly developing area that holds significant potential.
Dry endoscopy. So working without the constant fluid irrigation.
Exactly. Dry endoscopy avoids fluid extravasation, relying on alternative methods of distension. and is seen as a key area of development because it reduces the risk of fluid leakage and swelling, particularly in those extra-articular procedures we discussed. By incorporating extra working portals and adapting refined techniques from open surgery, dry endoscopy is already allowing for sophisticated procedures such as the precise excision of the olecranon bursa, comprehensive nerve releases around the elbow, including complex ulnar nerve transposition, deep fascia repair, suture anchor insertion, and even distal biceps tendon repairs. This less invasive approach, when safely performed, significantly reduces morbidity, meaning less tissue damage and faster healing, while preserving the full efficacy of the procedure. We fully expect to see this technique become even more widespread and refined, becoming the norm for many soft tissue procedures.
That's a truly exciting development, especially avoiding the fluid extravasation issues. What about within the joint itself, perhaps for larger reconstructive procedures like arthritis?
Beyond dry endoscopy, we anticipate significant advancements in arthroscopically assisted arthroplasty. For debilitating conditions like elbow arthritis, both osteoarthritis and post-traumatic arthritis, arthroscopic surgery is an increasingly viable option when conservative measures fail. Ulnohumeral arthroplasty, which involves creating a large drill hole between the olecranon and coronoid fossae to vent the distal humerus and remove impinging osteophytes, has already shown good results in restoring motion and alleviating pain. Looking ahead, we anticipate the development of fully arthroscopic interposition arthroplasty, or even prosthetic arthroplasty. Imagine replacing joint surfaces with minimal invasiveness that would represent a major leap forward in joint replacement for the elbow.
Fully scope-based joint replacement. Wow.
It's on the horizon. Biologic resurfacing of the radiocapitellar joint is another highly probable future application. This would involve using advanced cannula systems to precisely insert biologic grafts, perhaps cartilage from another area, into the elbow joint, which could then be secured with sutures or suture anchors. Similarly, we foresee arthroscopic assistance through small incisions, facilitating prosthetic replacement of the radial head or capitellum, further expanding the scope of minimally invasive elbow surgery and offering patients new options for complex conditions that traditionally required larger, more open approaches. The relentless drive for smaller incisions, reduced recovery times, and ultimately improved patient outcomes will continue to fuel these exciting innovations. The key insight for the future is a continuing shift towards even less invasive techniques, enabling surgeons to tackle previously challenging problems with greater precision and fostering more complete, faster patient recoveries.
What an enlightening deep dive into elbow arthroscopy. From the intricate details of safe portal placement and nerve protection to the nuanced management of complex conditions like OCD, instabilities, and fractures, and even looking ahead to the future with fully arthroscopic arthroplasty, it's clear this field is constantly pushing the boundaries of what's possible in orthopedic surgery.
Indeed, the seamless blend of profound anatomical understanding, cutting-edge technological precision, and rigorously tailored rehabilitation protocols continues to improve patient outcomes dramatically. This truly allows individuals to regain function and confidently return to their active lives, often with a renewed sense of possibility.
As we consider the incredible precision and expanding scope of minimally invasive elbow surgery, perhaps the true next frontier lies not just in refining these surgical techniques even further, but in our collective ability to seamlessly integrate these advances with even more personalized and responsive rehabilitation protocols. This synergy will truly optimize each patient's unique journey back to full function, regardless of the challenge they face. If you found this deep dive insightful, please take a moment to rate and share our discussion with your colleagues. Thank you for joining us on the Deep Dive.